Welcome. Tonight we're going to do another AMA. Thank you for those patients who and potential patients who've submitted some questions ahead of time. I saw some real good ones tonight. Some interval training. Let's talk about Oura Ring and the new features. So I'll answer those. And if you have new questions, just drop them in the comments and we'll start answering them. All right. So first question up tonight. The Oura Ring shows my cardiovascular age is 4 years higher. What can be done about it? So the Gen 3 version of the Oura Ring has two new cardiovascular features. One of them gives you a arterial age, and also you can get a calculated VO2 Max. So I've been using the Oura Ring since 2017. Took some time off of it because my sleep's been dialed in for a long time, but upgraded to the Gen 3 so I was able to get this feature turned on. So you got to have at least 2 weeks of data before it'll calculate it, but it's looking at your pulse wave velocity. So essentially, as the blood is going past the sensor, the arteries are going to expand and be contracting, and that's what that sensor is measuring with the photoplasmography or the colored lights. So in my office, I use a device called the Max Pulse. That's what's looking at the elasticity of the arteries and gives you a pulse wave velocity where if your number is low, you have elastic arteries. If your number is high, you have stiff arteries. Stiffer arteries or sicker arteries. Sometimes it's due to nitric oxide. Sometimes due to oxidative stress and inflammation, high insulin, infections. There's many things that can damage the lining of the arteries. But if your arteries are stiff, it's going to give you a higher arterial age. So you have to look at, are there any known risk factors? I wouldn't suspect people who follow me wouldn't be smokers, but if they're smoking, gotta look at that and stop that. If you're insulin resistant, high glucose, high insulin, try to reverse that. Focus on muscle-centric medicine, get your muscles healthy. Then there's a whole host of biomarkers you can look at, oxidized LDL, uric acid, homocysteine. So usually you can figure out the root cause of it if you do kind of a deep dive on the blood analysis, and then just look at your lifestyle. So exercise, nutrition, sleep, stress management. All right. Person reports that their primary wants to put them on a statin for high LDL. I will assume that this is LDL-C and not LDL particle. If you have access to particles, it always predicts risk better than just traditional LDL-C. The person wants a calcium score test, and then they wrote new primary time. Possibly. Calcium score test is a good tiebreaker at times. If your calcium score is over 300, definitely should consider a statin. That's even part of the traditional guidelines. Calcium score is 0, depends on your age, but you may consider delayed treatment if that's the case and your score is truly 0. Risk of a heart attack is very low, about 1% over the next 10 years or so. So can't recommend that you necessarily fire your primary, but if you're not having a civil discourse with whoever's helping you, on your health journey, then you look for somebody who can help you with that. All right. So this is one of those questions where I can't answer it directly, so I can talk in generalities because this is a question you have to ask the person that's treating you. But somebody's reporting, is it okay to do high-intensity interval training with a very high-risk calcium score? So the high-risk calcium scores are over 1,000. The person says they have no symptoms, and they have a VO2 max of 49. It's going to depend on your age, but that's generally going to be very good. VO2 max of 50 is kind of the cutoff to say, things are looking pretty good for you. But calcium score over 1,000, the risk of having a significant coronary stenosis is not low. So you would probably want to do some type of stress test to say that you don't have ischemia with exercise before saying it's good to go for doing interval training where you're getting your heart rate up to 80-90% of your maximal predicted heart rate. So it's possible, but you can't do it with a little bit more testing probably. And I often get that question when I see patients. Exercise is the best medicine for your vascular disease, but you got to make sure that you can do it safely. How do you find the root cause of endothelial dysfunction? That's what we do at Cardiology. That's what our office is set up to do, is find out why people's arteries are aging faster than they should. So we look at a combination of biophysical and biochemical markers. So we do the Max Pulse, do the endopat, that's looking at nitric oxide availability, and then blood work. Some of the quick tests you can look at is your urine microalbumin creatinine ratio. If that's high and you're leaking protein in the urine, that means that the lining of the arteries is getting damaged. To the kidneys, likely endothelial dysfunction in the heart, brain as well. Uric acid, if it's high, damages the endothelium. Homocysteine is high, causes something called ADMA to be high. That lowers nitric oxide, arteries get stiff. High oxidized LDL, high insulin. There's lots of things that can damage the glycocalyx and the endothelium. And a good history, physical exam with some non-invasive testing, and some blood work usually gets to the root cause. Next question up tonight. This is one of the ones where I'm not going to know the difference. Berberine versus berberine hydrochloric acid. Is one better than the other? Is one a mild PCSK9 inhibitor? One better for glucose? I don't know off the top of my head. But berberine is a supplement. It's a kind of alternative to metformin at helping with glucose control. So some patients prefer to use that instead of going straight to glucophage or metformin. And then in my practice, I tend to use it more for that other case that you mentioned. It is what I consider a weak PCSK9 inhibitor. So PCSK9 is the enzyme that degrades your LDL receptor. Your LDL receptor is like the docking station that's plucking the ApoB particles out of the circulation and delivering them to the liver. Berberine just makes sure that enzyme is blocked a little bit, and so those receptors stay out longer to pluck the ApoB particles out of circulation. So I don't know the difference between those two, so it would depend on the brand. So I typically use a lot of orthomolecular CM core for my berberine. How soon after an intervention can you test for changes in ApoB, oxidized LDL, etc.? 3 months, 6 months? It really depends on most part, like, do you want insurance covered or are you willing to pay cash? You can see changes in 2 weeks of some of these metrics, but most of the time you wait 4 to 6 weeks before checking anything. 6 months you'll definitely see an effect, but if you're wanting to be more aggressive, I usually have patients check things 3 to 4 months after doing a change and adding, either a statin, adding PCSK9 inhibitor, adding ezetimibe, or if they're doing supplements, recheck in 3 to 4 months. Actually, I have a finger stick called cholesterol check. It's in my office. It's a finger stick. It just gives you traditional lipids, so total cholesterol, HDL cholesterol triglycerides, and a calculated LDL cholesterol. So it's a rough guide. So I've been using that recently because I've been doing some kind of biohacks. And you can check daily if you want it. Now, is that clinically relevant? No. Is it that beneficial? No. So I usually check it every 2 weeks when I'm using that. What is your ultimate heart-healthy breakfast? It would be seafood. Getting a high dose of DHA for breakfast would be outstanding, and then make sure you're getting at least 30 grams of protein. That's what I would start with if you could do that. Are vagus nerve stimulators helpful for stress? They can be, but that's obviously implantable. Well, some of them are implantable. I should back up. There are some that are external where you can put it over your neck and then stimulate the vagus nerve. I don't, in my practice, use those very much. I mean, that's what could be more for kind of like a pain management doctor or a neurologist. But, with a device works, but you can also stimulate your vagus nerve with deep breathing exercises. I tend to recommend a device, a couple of devices, honestly. One's called Heart Math. It clips your ear, it measures heart rate variability, and then leads you through breathing exercises. So you're stimulating the vagus nerve with that. There's a device called the Respirate device that can also stimulate the vagus nerve non-invasively. So can it helpful for stress? It can be, but I haven't played around with them very much. There are implantable ones too, but I don't think you're talking about the implantable ones. All right. High cholesterol. This person's doctor wants a statin for them, but the person is resisting getting started on therapy, but they're going to get a CT and another lipid panel in July. Advice. So again, I can't give you direct medical advice. You have to work with the person who's ordering the test for you, unless you're one of my patients at Apollo Cardiology. But it's always a combination of biochemical, the blood test, that just kind of tells you, for the most part, what's going on in that person's environment. But it's much more useful to know what's going on with the arteries. So that's testing for your endothelial health, blood pressure, carotid intimal thickening, do you have inflammation in the artery, and then doing your calcium score test or a CT angiogram, particularly if you do a CT angiogram with the Clearly AI overlay, you get a good idea like what's going on with your arteries. Then the blood work just helps you determine the root cause of why do you have plaque in the arteries or you have endothelial dysfunction and what you can do about it. Sorry to hear about this one. Somebody says, what can you do about a blood clot in the heart while undergoing chemo for breast cancer? Malignancies are a hypercoagulable state, so blood is more likely to clot and get left ventricular thrombus. Often patients would have to get started on anticoagulation with either warfarin or one of the NOACs. Often it's Xarelto or Eliquis, but it's going to be one of those cases where that is kind of par for the course, unfortunately, for some cancers. So you'd have to talk to a hematologist about how long they want you to be on anticoagulation. The short answer should be yes. So is there a way to quantify your success in preventing heart attacks? How do you view success? You don't show up in the hospital in the middle of the night going to the cath lab and getting a catheter threaded up your arteries into your heart and getting a stent deployed, or getting your sternotomy and getting a bypass graft. So that's how I view success. I can tell you in the 5 years that I've had Apollo Cardiology open, none of my patients have gone for bypass surgery. And there's been a couple patients get stents electively as outpatients because they failed stress tests and were still having symptoms despite optimizing medical therapy. So I don't necessarily, quantify that as a failure. Just use whatever therapies make the patient have the best quality of life. But to my knowledge, I've not had a single patient in 5 years present to the hospital unexpectedly for an angiogram because of a heart attack. So I view that as a success. How can a visit to the tropics in the fall or winter provide benefits for heart and arteries? Well, I'll back it up a little bit. It's going to depend, for the most part, what is your maternal haplotype? So if you've had a 23andMe, you can assess, where your original maternal lineage came from. It's really about mitochondria. This is mitomike minute, essentially. So if your mitochondria are more northern latitudes, then your body's equilibrated to stay in the northern latitude in the fall or winter. You can use more cold therapy. If you're more of an equatorial haplotype, you're supposed to be more, in the tropics all year long, not just in the fall and winter. So that's the default. But if you don't know your haplotype, or you just want to know, hey, could you benefit? Well, light always trumps cold for the most part for helping people optimize their mitochondrial function. So, at least where I'm at in St. Louis, we have 4 seasons. The winter doesn't get tremendously cold, but it gets, very gray and, shorter days. And, seasonal affective disorder is pretty common where I'm at. Not me personally, but lots of people that I know experience it. So, often in January or February, we'll do a sun run down to Mexico, often to Cancun. There's good bioenergetics there. You can ask me later why I choose that region if you want. But do a sun run for a week or two, absorb a lot of photonic energy, ground, drink some good water, eat a lot of seafood for breakfast, and then come back. And then it takes maybe 6 weeks for that kind of a mitochondrial recharge to wear off, and then you can do it again, or hopefully you already make it through to the springtime. So that's how a sun run would help benefit some people. Is it possible to lower lipoprotein A? Yes, but with a caveat. So the only way that it really effectively does it is something called apheresis, which is essentially like dialysis. They take your blood out, put it through a machine, give you your blood back. Most people aren't necessarily going to sign up for that because you got to continually do it. Now, I don't know exactly the exact cadence, but it's a couple times a month. There are some places at big medical centers that do that. Much more popular in Germany than in the States. In the States, PCSK9 inhibitors are off-label for this. This is Repatha and Praluent, but in those studies that were studying it, the Odyssey trials, LPLA could be lowered up to about 30% with the PCSK9 inhibitors. But again, that's off-label, so often insurance companies are not going to cover it unless there's another reason that you're on it. you're statin intolerant, you've already had a cardiovascular event, and you're at high risk of having recurrent events, then they'll typically cover PCSK9, and you get the added benefit that LPA is going to get lowered with it. The small interfering RNAs and the antisense oligonucleotide medications, those are on the horizon and should hopefully be coming out in the next year or two. They're going to lower LPLA by 95% or greater. So they're already in phase 3 trials, so just be on the lookout. I'll definitely talk about them once they actually go to market. But in the interim, just because you can't lower LPA doesn't mean you can't do something about it. You can lower ApoB on your LDL particles with multiple different lifestyle interventions, supplements, and medications. You want to have oxidative stress very low, particularly oxidized phospholipid ApoB, interleukin 6, LPPL-A2 activity. Those are the 3 big labs I look at for people with LPLA. If those labs, LPPL-A2 activity, OXPL, ApoB, and interleukin 6 are high, then LPA is much more likely damaging the arteries. Good question. So somebody's asking me, how do I decide yes or no on statin for high ApoB, 126, prior to treatment? So ApoB by itself doesn't automatically mean statin should be in your drinking water. What are your arteries' health looking like? So if you have endothelial dysfunction, if you have vascular inflammation on blood tests and on carotid scans, if you have soft plaque in your carotid or coronary arteries or hard plaque, it's reasonable to start driving the ApoB down further. So 126 is well above the 50th percentile. It's probably about the 80th percentile. If you have plaque in the arteries, generally I like to see people less than the 20th percentile. So an ApoB under 70. So that's how I first started thinking about it. But I will often do blood testing to figure out if pharmacogenomically the patient's likely to tolerate statins. So if the person has an ApoE4 allele or they have an SLCL1B allele, they're more sensitive to probably having muscle side effects on statins. The Boston Heart Lab panel also has a test called the cholesterol balance test. If you're a hyperproducer of sterols, meaning your liver's cranking out a lot of lanthosterol and desmosterol, that's the location where statins would tend to benefit more. If you're not a hyperproducer of sterols, but rather a hyperabsorber of sterols, and the issue is more in the gut, often ezetimibe might be a better starting option for that person. But again, it's going to always depend on what's going on with your arteries. If you're for primary prevention, you just have, quote, high ApoB, maybe you're going to do some lifestyle interventions first. Or if you're going to try supplements, I mostly say 3 to 4 months of doing whatever you're going to do. And if it's not improving, then figure out what pharmaceutical therapy is going to likely work well for that person. But if you've recently had a stent, stroke, bypass, you're very high risk to have another event in the short term. So use the more aggressive options. So that's how I would think about ApoB in that case. What does heart arteries need most in 100 Fahrenheit degree? How long to be safe outside? Good question. So I was just in Tucson, Arizona the other week at the Canyon Ranch, doing some recharging and doing some mind-body works. And, the daytime temperature was 112 degrees most of the time Fahrenheit. So it's kind of like a, infrared sauna without, having to be in a box. So it really depends on, your, heat tolerance to begin with, and your physical conditioning to begin with. Because when you get to the higher temperatures, it's like exercising. It's going to increase your heart rate. So you definitely want to stay hydrated. You definitely want to keep your electrolytes, up. So, I tend to use a lot of LMNT, or you can use the, sugar-free, liquid IVs if you need to. But how long to be outside? Well, it depends on why you're outside. If you're doing it for vitamin D, well, use the D-Minder Pro app. Get your vitamin D exposure time and go back inside or get into the shade, So it really depends on why you're outside and, how long. It really depends. But if you're feeling dizzy, lightheaded, feel like you're going to pass out, you got to hydrate and get back inside. Because, when I was an internist back many years ago, I was at Naval Hospital Beaufort taking care of a lot of the Marine recruits at Paris Island. And we saw a lot of heat strokes, in July in, Beaufort, South Carolina. Recruits would have, internal body temperatures of 105, 106 degrees, and, your muscle proteins really start significantly breaking down. You start getting rhabdomyolysis at that temperature. So you definitely got to be careful, if you're prone to heat stroke or heat exhaustion. Question, does taking a fiber supplement actually help with lowering cholesterol? In my experience, very marginally. So if you have a lot of lipoproteins to go, fiber alone isn't going to be the answer. Might help a little bit, but it's much more about for bowel regularity than it is for lipid lowering. Why can't you take quercetin when taking Crestor, which is also known as rosuvastatin? I have not seen that particular supplement drug interaction. Quercetin most time is used for patients who have certain allergies. Some patients are taking it, to help with senescent cells. So it depends on why you're on both of them. But I haven't seen it myself, so probably would have to ask a pharmacist if there's really a contraindication for those. But if you're on Crestor, and quercetin, if you only could pick one, I probably would pick the Crestor because there's data that can help regress plaque in the arteries. What are my thoughts on low-dose aspirin for elevated LPLA? Some recent studies look promising. So I pretty much default that if you have high LPLA, I do recommend aspirin, 81 milligrams, generally taken in the evening time. LPLA does increase the risk of atherosclerosis as well as thrombosis or blood clotting. So that is one of the cases where, aspirin for all, no, the risk of bleeding, tends to outweigh the risk of lowering stroke and heart attack in many individuals. But if you have LPLA, that's often the tiebreaker that I'll say, it's reasonable to take a low-dose aspirin, unless the person has, a history of peptic ulcer disease or, kidney failure and, NSAIDs are contraindicated. All right. So about 20 minutes in on the pre-submitted questions. Thank you guys. Those are some really good ones. We will be obviously keeping this in my feed, so you can watch the replay if you're joining in here. And I will take these videos. I always run them through a transcription feature and then put them up on my YouTube channel, which is just drtwyman.tv, or if you go to YouTube and just search Dr. Twyman, you'll find the page. But I'm starting to work on some longer form videos to put up on YouTube. There's also going to be a community launching, and pretty soon this guy have a little bit more behind the scenes way that I think about vascular health, which I can't put out here, to the wide audiences. So it'll be a little bit more specific. So if you're interested in that, just stay tuned for that. So there's a few other questions popping up that I see in the comments, and so I'll start hitting on those. Question, what do I know about microvascular angina? A whole bunch. It's related to endothelial dysfunction. It starts with glycocalyx disruption. So 99% of your blood vessels are part of the microcirculation. The microcirculation is very small. It's reported that 100 microvessels would fit inside the diameter of one human hair. And so you need all the microcirculation working to bring in oxygen nutrients to the tissues and then getting the waste products out. So it was not an uncommon situation when I was still an invasive cardiologist that we would do an angiogram, go in there and tell people, you just got minimal blockages in your coronary arteries, you don't need a stent, good to go, take some medicines. But the person would still have symptoms. They're like, why do I have chest pain? Well, we used to say that, maybe it's not cardiac chest pain and you should get worked up by an musculoskeletal specialist, or you need to go to a pulmonologist, But in hindsight, probably a lot of it was microvascular disease, endothelial dysfunction. So got to work on optimizing nitric oxide and endothelial glycocalyx and trying to get to the root cause, what might be driving some of the microvascular dysfunction. Low nitric oxide, endothelial health issues, have a deviated septum and enlarged terminates. If it gets surgery, would this help endothelial health? I have a decent amount of plaque on Crestor 5 milligrams. Unknown. Nitric oxide is produced on your endothelial cells as well as your epithelial cells in your nasal cavity. Anytime surgery is done, you're going to be damaging those cells. Unknown, does they come fully back online? So I wouldn't rely on just nasal breathing to improve your nitric oxide. It's just one of the pathways. You have to optimize your exercise, your UVA sun exposure, nitrates in the diet. Don't use fluoride. Don't use mouthwash. Don't block acid in your stomach if that's an option. And that gives you the best potential to make nitric oxide at baseline. But so many people are dysfunctional, and fortunately there's many nitric oxide promoting supplements on the market that work well. So you have a lot of plaque in the arteries. Crestor is a good starting point, but it's not the be-all, end-all of it. That's one of the reasons I ended up leaving the cath lab many years ago. Almost every patient that came in with a heart attack was already on a statin. If statins were all magical, we'd all take them and nobody would have a heart attack. So you have to fix the endothelial dysfunction, the vascular inflammation, and anything else that's causing the plaque to build up. It's not just about using a statin and lowering ApoB. Somebody's LPA is 518. Any suggestions with a calcium score of 19? Have an ApoB of 55. Have oxidized ApoB, oxidized phospholipid ApoB low. Interleukin 6 low. LPPLA2 activity low. And then, that is one of the cases where you probably got 2 copies of the gene. Potentially one from mom, one from dad, or you got 2 different alleles that drove your LPLA higher. The higher the LPA, the higher the risk of vascular disease, the higher the risk of aortic stenosis. So you got to try to work on all your other risk factors as you can. But this is the case where you might want to talk to your doctor. Are you a good candidate to be on a PCSK9 inhibitor, or Patha or Praluent are the main ones that people consider. I'm seeing a few familiar names on here. So a few people are the people that come see me at Apollo. Right now, my practice is still open to new patients. Probably not for much longer because it's just myself, but I will have some options for patients if they can't travel to see me, or I ultimately fill out my practice. I'll have kind of a plan B option for some people, but I do see a few people that have made the trip out to St. Louis, so welcome again tonight. It's important to find your mother's genetic lineage for mitochondrial health. If you can get access to it, yes. 23andMe has access to it. I believe Ancestry probably does too. It's going to be on the first page of the report. It'll say maternal haplotype. Question: how often should we have a heart CAC test done? CAC stands for coronary artery calcification test. So here's the kind of it depends answer. If your score is 0, generally 3 to 5 years later. If your score is over, let's say, 300, it's the equivalent. You've already had coronary artery disease, already had a heart attack, you're higher risk. There is no reason to ever repeat the scan again. Less than 300, it's debatable. But it's one of those cases where, often a lot of the treatments are used to help stabilize plaque. We're taking soft-vulnerable plaque and making it hard calcified plaque. So often, if you add a statin or if you add certain other nutraceuticals, the calcium score test will keep going up. You're not actually getting worse. You're taking the stuff that's going to cause a heart attack and calcifying it, basically turning it into a scar. So for the most part, if your calcium score is above 0, I rarely recommend repeating it. If you really want to know if the plaque is getting better, you should do a CT coronary angiogram to look at that, ideally with the Clearly analysis. All right. So somebody's asking about omega-3s. They're asking that, I'm not necessarily a fan of omega-3 supplementation. Why is that? Is it possible to get enough from food? It's definitely possible to get enough from food, but you generally got to eat seafood 3 times a week or greater. On the blood work, I'm looking at either the mega check, the mega quant level to see, are you getting enough omega-3s through your diet? DHA is critically important for retinal health and brain health. You can almost think of DHA as your cell phone charge. If it's not above 100, you're potentially not going to work at full capacity all day long. The reason you want to not consider supplementation is that it comes down to quantum mechanics. There's a triglyceride backbone. There's the SN1, SN2, SN3 position. You need the omega-3 to be in the SN2 position, the middle position, to be able to get into the cells like a key. If you take a supplement, it may not be in the SN2 position. This is why algae oil probably will not work for people. Your blood levels might be higher, but doesn't mean it's necessarily getting into your cells. It's like a key problem. So that's why I'm not a huge fan of omega-3 supplementation. That being said, there are some people who just absolutely aren't going to eat the seafood. Is it better than nothing? Possibly, but it has to be, discussed with the person who's treating you, because there are certain reasons why you should not be taking it in some instances. So that's why the default is try to get it from real foods when possible. What lifestyle interventions do I recommend to lower ApoB? Exercise has a role, but it's not a significant role. There's a lot of other benefits of exercise, more like keeping your blood pressure normal, keeping your insulin sensitivity normal, lowering inflammation, lowering your risk of diabetes and Alzheimer's, cancer risk. But it doesn't really have a significant effect on ApoB in most people. So, should be shooting for, resistance training at least twice a week and 150 minutes of moderate cardio activity a week. And that's going to be your best, approach that, like, okay, I've done enough baseline exercise to see, is it having an effect on ApoB? There's a lot of nutrition interventions some people can try. Just make sure you're not insulin resistant. If you do a fatty acid balance test on the Boston Heart Lab panel, you'll know if saturated fat's really an issue for you, or if you have an ApoE4 allele. Sometimes you're going to have an issue that it's driving up your lipoproteins, and then maybe you switch up to more of a paleo template or Mediterranean template, and your lipids will improve. So those are the main lifestyle interventions. Are walnuts good for heart health? They are in ways. They have a lot of ALA. Some of it will convert to other sources of omega-3, so they can be. But it's a very inefficient way to get all your omega-3s. So I've never seen anybody eat enough walnuts to get enough omega-3s, and you gotta be careful if you have a history of kidney stones, I believe. How do we measure nitric oxide? This could be like a 5-hour podcast if I did that, but the short answer is you can do salivary nitric oxide test strips. They're like litmus paper, put saliva on it. If it's white, you're not making much nitric oxide. If it's bright red, making nitric oxide. There's blood test, ADMA, SDMA, urine microalbumin creatinine, homocysteine, uric acid. Those all have effects on nitric oxide if they're abnormal. And then in my office, I do a lot of testing that looks at arterial elasticity, so that's the max pulse test. You want the arteries to be very elastic. Blood pressure is a marker of nitric oxide availability, so blood pressure should be less than 120/80. If it's not, often you have low nitric oxide. And then if you have evidence of inflammation in your arteries, basically that your force field is down. Nitric oxide puts a force field up, preventing the lipoproteins and the white blood cells from sticking to the arteries. So you can kind of look at the arteries. If there's a lot of inflammation in them, you probably have low nitric oxide. So we do a battery of tests to figure out why nitric oxide is low, and if needed, supplement them with things that help promote nitric oxide availability. Someone wants to know a little bit more about the logistics of working with us and cost structure. It's going to depend on what you're interested in. If you're interested in potentially working with us, you can just go to my website, drtwyman.com. There's an application up at the top of the page. One of the members of my team would set up a Zoom call with you and walk you through all the logistics about how to work with us. Definitely not an expert on this next one, so I don't have significant thoughts on it, but thoughts on spirulina and chlorella can help with some of the detoxification pathways, from certain metals. So not against them, but I don't know the exact dosages to recommend for them, but not likely to be harmful. What are the best sources of omega-3s? The best one would be oysters, if people would eat them, but most people eat fish, so it's usually the smash fish, salmon, mackerel, anchovies, sardines, and herring. You can also add tuna to the regimen. So that's the best sources of most people. All right. I think I got through all the questions here. So I appreciate everybody's time and attention tonight. This will be obviously in my feed in just a moment. I'll be back next Monday, 6 p.m. Central Time, to do it all again and answer the questions. I'm going to be doing a podcast this Friday with Dr. Alexis Cohen. It's going to be an outstanding quantum biology talk. She recently did a podcast with my good friend Dr. Gabrielle Lyon. So if you follow Dr. Lyon, the podcast was released about a week or so ago. Dr. Lyon's podcast, was outstanding with her. She goes through, the basics and deeper than the basics on how the mitochondria work and how light interacts with it. So I'm going to do more kind of the vascular part with her. So be on the lookout for that podcast. But in the meantime, maybe check out her podcast with Dr. Lyon. So appreciate it. We'll see you guys next Monday, 6 p.m. Central Time.